Good evening, everyone. Thank you for that kind introduction. So, today I will be discussing preoperative risk assessment in children, specifically how we identify, stratify, and manage perioperative respiratory risk. So, as pediatricians, we are frequently asked to provide preoperative clearance. However, one of the key messages from this lecture is that our role is not really to clear patients for surgery. Rather, to understand the risk, we should be able to communicate this risk and help the perioperative team make the safest possible decision for the child. So, by the end of this lecture, I hope we can shift our mindset from asking, is this child cleared for surgery? To asking, what is this child's risk and what can we do about it? I have no relevant financial or non financial disclosures related to this presentation. So by the end of this lecture, we should be able to define preoperative risk assessment as risk stratification for pediatric perioperative respiratory adverse events or PRAEs. Secondly, we should be able to identify the three major domains that contribute to perioperative risk, such as patient-related factors, surgical risk, and anesthesia-related risk. Thirdly, we should be able to classify patients as having mild, moderate, or high risk for PRAEs using available assessment tools. And finally, we should be able to formulate appropriate recommendations based on the overall risk profile of the patient. So many of us pediatricians still use the term preoperative clearance. However, in reality, there is no child that has zero risk of developing perioperative complications. Even a completely healthy child undergoing a minor procedure still carries some degree of anesthetic or surgical risk. Therefore, our role is not to declare that a child is risk-free. Our role is to identify the risk factors, estimate the likelihood of complications, determine whether this risk can be modified, and communicate these findings clearly to the surgeon, anesthesiologist, patient, and the family. In other words, we do not clear patients. We assess for their risk, and that risk assessment should take into account three major domains. We have the patient-related factors, we have the surgical factors, and we have the anesthetic factors. Now, if our role is risk assessment, then the next question becomes, what exactly are we trying to prevent? So the answer to this question is pediatric perioperative respiratory adverse events or PRAEs. These include laryngospasm, bronchospasm, oxygen desaturation, airway obstruction, aspiration, apnea, prolonged intubation, reintubation, stridor, and severe cough. These complications are among the most common causes of perioperative morbidity in children. Fortunately, many of these complications can be prevented if the risk factors are recognized before surgery. So the goal is to identify these patients who are more likely to develop these complications so that the preventive strategies can be done. So now let's discuss to the three major domains or major factors that would affect preoperative risk assessment. The first domain that we should consider would be patient-related factors. These factors increase the risk of having adverse events during surgery. These are younger age, specifically infancy, history of prematurity, ASA physical class 3 or higher, the presence of comorbidities such as acute respiratory tract infection, history of bronchial asthma, congenital heart disease, obesity, and obstructive sleep apnea. Now let's tackle each one. The first factor is age. Infants younger than 1 year have the highest incidence of perioperative respiratory complications. This is largely because of their unique physiology, which includes having smaller airways, having more compliant chest walls, periodic breathing, and earlier airway closure. As a result, They are more susceptible to laryngospasm, apnea, airway obstruction, bronchospasm, and oxygen desaturation. The next risk factor is prematurity. Former preterm infants have significantly higher incidence of adverse perioperative events compared to term children. Important concerns include bronchopulmonary dysplasia, post-operative apnea, and airway obstruction. Now, based on evidences, even if the child is no longer a neonate, a history of prematurity should always prompt us to have a more careful respiratory assessment. The third risk factor is the American Society of Anesthesiology Physical Status Classification. This remains as one of the simplest and most useful tools for risk stratification. ASA1 represents a healthy child. ASA2 represents mild systemic disease, such as a controlled asthma, mild obesity. ASA3 refers to severe systemic disease, such as uncontrolled asthma, uncontrolled seizures, or congenital heart disease with functional limitations. ASA4 refers to severe systemic disease that is a constant threat to life, such as sepsis or advanced cardiac failure. ASA5 is moribund. Patient is not expected to survive without the surgery. And ASA6 is a brain dead child who is also an organ donor candidate. Now, pediatric ASA classification 3 or more increases perioperative complication risk by 4 to 14 times, higher incidence of desaturation, higher incidence of reintubation, cardiac arrest, or even death in a Thai study. Now, one of the most common situations we encounter is a child with respiratory tract infection, whether upper or lower. Respiratory infections increase the risk of perioperative respiratory adverse events, including laryngospasm, bronchospasm, and oxygen desaturation. In general, lower respiratory tract infections carry a higher risk than upper respiratory tract infection. However, the presence of respiratory infection does not automatically mean surgery can be canceled. Instead, we should ask two key questions. First, where is the child in the course of the illness? For elective procedures, children who have been asymptomatic for at least 2 weeks after an upper respiratory tract infection are generally considered lower risk, whereas recovery of at least 4 weeks is preferred after a lower respiratory tract infection. Second, will postponing the procedure meaningfully improve the patient safety? So this question becomes especially important when surgical urgency is considered because not all procedures can or should wait for complete recovery. Another factor would be the presence of history of bronchial asthma. Poorly controlled asthma is one of the strongest predictors of perioperative respiratory complications. When assessing asthma, we should look for evidence of poor control. Has the patient required oral steroids recently? Has there been increased use of rescue medications? Have there been recent emergency room visits or exacerbations? For elective surgery, asthma should ideally be optimized before proceeding because unlike many risk factors, asthma control is often modifiable. So, for a scheduled elective surgery, there should be at least 4 weeks that the patient is asymptomatic before classifying the patient to low risk. Another factor would be congenital heart disease. The presence of congenital heart disease increases both respiratory and cardiovascular complications. Particularly concerning features include cyanosis, cardiac failure, younger age, and complex cardiac lesions. Identifying these high-risk patients early allows appropriate planning and perioperative monitoring. The next factor would be childhood obesity. Childhood obesity is increasingly common, becoming common. These children often have narrowed upper airways, obesity hypoventilation, asthma, and obstructive sleep apnea. From an anesthesia standpoint, obesity increases the likelihood of difficult mask ventilation, difficult laryngoscopy, airway obstruction, and oxygen desaturation. Another factor would be the presence of obstructive sleep apnea. Obstructive sleep apnea deserves special attention because many children remain undiagnosed. Historical clues include snoring, witness apnea, daytime sleepiness, and poor quality of sleep. These children are at increased risk of airway obstruction, hypoxemia, post-operative respiratory complications, and ICU admission. So, recognition before surgery is therefore extremely important. In history, we can use the STUBR or Stubber questionnaires to identify patients at risk of having obstructive sleep apnea. The questions would include: does the child snore more often? Does the child snore loudly? Or does the child have any trouble breathing? Has the child stopped breathing at night or a witness apnea? Or has your child felt unrefreshed after a night of sleep? So when there's three of the five symptoms are present, then the child is three times more susceptible to PRAEs. In physical exam, we can use the Malampati scoring to examine the pharyngeal inlet. Malampati describes the degree of oropharyngeal crowding. It measures the visibility of the tongue, tonsils, uvula, and the soft palate. Now, the assessment is typically performed by having the patient sit upright, open their mouth wide, and protrude their tongue without saying ah. So, another patient-related factor that is quite controversial would be identifying patients who are at risk using laboratories and ancillaries. A common misconception is that more tests would automatically mean a safer patient. In reality, routine laboratory testing is not recommended for every child. Laboratory investigations should be selective and guided by clinical findings and the planned procedure. So, good history and physical examination remain far more important than a blanket laboratory screening. Here are examples of the laboratories or ancillaries that we can request and their corresponding indications. So, when it comes to the validity of the laboratories or ancillaries, or when preoperative tests are felt to be necessary, it is probably safe to use test results that were performed and were normal within the past 4 months, unless there has been an interim change in clinical status. Now let's go to the second domain, which is the surgical factors, which includes surgical urgency and surgical complexity. First, let's discuss the surgical complexity. One way to discuss or to classify surgical complexity is through the surgical risk quartiles, as studied by Nasser et al. Nasser et al. Studied the surgical procedures extensively based on the 30-day post-operative mortality. Low-risk procedures, or the first quartile, include surgeries such as hyposphagia repair or orchidopexy. Moderate risk procedures, or the second quartile, include appendectomy and cleft palate repair. Higher risk procedures involve or include foreign body bronchoscopy, pull-through procedures, tracheostomy, and exploratory laparotomy. Understanding where your procedure falls on this spectrum help us contextualize the patient's overall risk. The list is quite extensive, and it is included in our PAPP position statement for preoperative evaluation. Another useful framework to stratify surgical complexity would be what we call the NARCO SS. surgical severity classification. This is based on the invasiveness of the procedure as compared to the one used by Nasser et al., which is based on a 30-day post-operative mortality. So it is categorized into three. Category A procedures are generally minor or those that are peripheral or superficial in nature. Category B procedures involve greater airway manipulation or moderate physiologic stress. Category C procedures include major thoracic abdominal, neurosurgical, and airway procedures. So, as surgical severity increases according to category, the risk for respiratory complications would also increase. Now, after discussing surgical complexity, let's go to surgical urgency. We cannot overemphasize the importance of determining surgical urgency. Surgical urgency refers to the timing with which a procedure should be performed based on the potential consequences of delay. It reflects how quickly intervention is needed to prevent death, loss of organ function, disease progression, or other adverse outcomes. These help us guide in the perioperative decision making. So, surgical urgency is not a primary predictor of PRAEs. It does not directly alter the airway anatomy or airway hyperreactivity, but rather it influences whether surgery should proceed with concurrent optimization or be delayed for further optimization. So the same child with the same respiratory condition may receive completely different recommendations depending on whether the procedure is emergent, urgent, time sensitive, or elective. So the distinction is critical. Emergent procedures would mean delay may result in the loss of life, loss of organ function, or irreversible physiologic deterioration. Urgent procedures, on the other hand, would mean delay may result in significant morbidity, disease progression, or increased risk of complications, although immediate intervention is not required. Time-sensitive procedures would mean delay may adversely affect clinical outcomes, quality of life, growth, development, or disease progression, but a brief period of optimization is acceptable. Elective procedures, on the other hand, would mean delay is unlikely to result in significant harm, allowing surgery to be scheduled when patient and perioperative conditions have been maximized or optimized. Now let's go to the third and the final domain, which is anesthesia risk. Many perioperative respiratory complications are related not to the surgery itself, but to the airway management and anesthetic technique. Generally speaking, risk increases as airway manipulation increases. Also, the risk would depend on the level of sedation. Minimal sedation carries lower risk, while deep sedation or general anesthesia would carry the highest risk. Endotracheal intubation generally carries the highest risk of airway-related complications. So, the same patient may therefore receive different recommendations depending on the planned anesthetic approach. Now, although uncommon, malignant hyperthermia should always be considered. It is an important anesthetic consideration, and a personal or family history should always be sought. Recognition before surgery allows avoidance of triggering agents and preparation of appropriate treatment strategies. Again, our role is not to clear a patient for surgery, but to stratify the child's risk, particularly for perioperative complications such as pulmonary issues. The three main domains that we should deeply look into would be the patient-related factors, the surgical factors, and the anesthetic risk. Clinical judgment remains the foundation of assessment. That is why we consider these three important factors: the patient factors, procedural factors, and the anesthetic factors. They should be assessed all together. Then, um, Using the different stratification tools and scoring systems, we can synthesize these factors into a structured risk estimate, supporting a more consistent recommendations and clearer communication with surgeon, anesthesiologist, and the family of the patient. So it is important also to discuss the common tools and scoring systems that we use to synthesize the three different domains that I have discussed. These tools that we can use would be the American Society of Anesthesiology Physical Status Classification, or the ASA classification, and the Narco SS scoring systems. These tools help us organize the clinical picture and make the communication consistent. The American Society of Anesthesiology has been mentioned earlier. This is one of the oldest and widely used risk assessment tool. As discussed earlier, ASA Class 1 would refer to a healthy or an asymptomatic child. ASA Class 2 is a child with a mild systemic disease. ASA Class 3 would be or would refer to a child with severe systemic disease. And ASA Class 4 would mean that the child has a condition that is a constant threat to his or her life. Now, the only disadvantage with this assessment tool is that the surgical or procedural complexity is not assessed, which brings us to Narco SS. Narco SS is a pediatric perioperative risk stratification tool that incorporates both patient and procedural factors. The acronym stands for neurologic, airway, respiratory, cardiovascular, and other systemic conditions, with surgical severity score added as a separate domain. The key strength of Narco SS is the inclusion of surgical severity or complexity score, recognizing that perioperative risk is determined not only by patient comorbidities but also by the magnitude of the procedure. So for the score interpretation, 0 to 3 would mean low risk, so that's a total score already. 4 to 6 points would mean moderate risk, and more than 7 points would mean high risk. High scores are associated with an increased likelihood of perioperative complications and may warrant additional optimization, perioperative planning, or post-operative monitoring. After integrating patient, surgical, and anesthetic factors and formulating our risk stratification using the said tools, our next responsibility is to formulate recommendations. Recommendations would generally fall into three categories. If the risk is mild, then we can proceed. If the patient has moderate to high risk, but the procedure is urgent, then we can proceed with simultaneous patient optimization. Optimization may include nebulization, use of IV steroids, or IV antibiotics. If the patient has moderate to high risk but there is still ample time to optimize, then we can delay and optimize first. The recommendation would depend not only on the level of risk but also on the urgency of the procedure. Now let's go to the sample cases. Let's try to apply our framework. We have a 5-year-old child that was brought to the emergency room after a vehicular accident and requires emergency craniectomy. On history taking, patient has partly controlled asthma after finding out that there is presence of nighttime symptoms for the past week. Now, this child clearly has elevated respiratory risk. The surgery is an invasive neurosurgical procedure under general anesthesia. In this situation, the recommendation is not postponement. Therefore, even if respiratory symptoms point out to an increased risk of having PRAEs, the recommendation is to proceed while simultaneously optimizing the patient and preparing for potential respiratory complications. Now, for our second case, let's consider a child with recurrent tonsillitis and is scheduled for tonsillectomy. On history, however, patient has mild upper respiratory tract infection because of the presence of colds with clear nasal secretions and non-productive cough for 3 days. There is no history of asthma or chronic lung disease. Physical exam is normal except for boggy turbinates and grade 3 enlarged tonsils. Now, this patient has an increased risk for perioperative adverse events because of the respiratory infection. The surgery involves an invasive procedure which includes manipulation of the airways. So, however, the procedure is time sensitive rather than emergent, meaning to say there could still be ample time for observation or optimization. Since there is active since active upper respiratory infection increases respiratory risk and the procedure can safely be postponed, delaying the surgery until the airway has recovered will improve patient safety. Finally, consider a 2-year-old child scheduled for an elective hyposphagia repair. On history, patient has active lower respiratory tract infection as manifested by cough of 1 week. There's also presence of fever for 2 days. And on physical examination, you were able to appreciate crackles on the right lung. So your impression is pneumonia. There's no history of asthma and chronic lung disease. The procedure is elective. The respiratory risk is high because of the presence of lower respiratory tract infection. So the consequence of delaying surgery is minimal. Therefore, the patient has high risk for PRAEs, but since this is an elective procedure, postponement until maximal optimization represent the safest course of action. So to summarize, preoperative assessment is risk stratification, not clearance. Risk assessment should consider three domains: patient factors, surgical factors, and anesthetic factors. Risk can be classified as mild, moderate, or high. Finally, recommendations should be tailored according to both the risk level and surgical urgency. So the goal of preoperative assessment is not to determine whether the child is cleared for surgery or not cleared for surgery. The goal is to understand the risk of proceeding, to understand the risk of waiting, and to help the perioperative team choose the safest path forward. So risk stratify, optimize, and communicate. Here are my references. Thank you very much for listening.